Good morning. Welcome to the opening plenary session. During this discussion, we will explore the impact of social determinants of health in building a sustainable, healthy community. I am Dr. Nadia Richardson. I'm the founder of No More Martyrs, a mental health awareness campaign that seeks to build a community of support for Black women and girls. I am also a 2018 40 Under 40 Leader in Health Award recipient, so I'm very excited to be back here. Oh, thank you. I'm very excited to be here this morning to participate and to support this event in this way. I look forward to hearing the thoughts and insights of our accomplished and knowledgeable participants and panelists. Today's panelists include Dr. Deborah Arrindell, Executive Medical Director for Amgen, the Honorable Donna Christensen, former Chair of the Congressional Black Caucus Health Braintrust, Ms. Celeste James, Executive Director for Kaiser Permanente of the Mid-Atlantic States, Dr. Susan Rogers, internist with Physicians for the National Health Program, and we will be joined shortly by Mr. Derrick Johnson, National President of the NAACP. Also, Dr. Gloria Wilder, Vice President of Innovation and Preventative Health with Sistine Corporation. Thank you for being with us this morning. Give them a round of applause, yes. If you are following and participating in this discussion and tweeting at all, please send your questions to @NMQF. We will have a question and answer session where you'll be able to approach the mic with your question, but if you'd rather not approach your mic, you can send your questions that way as well, and we'll be able to address them during the question and answer session. Social determinants of health are the economic and social conditions that influence differences in health status. The World Health Organization found that social determinants of health are shaped by the distribution of money, power, and resources at a global, national, and local level. The CDC shares that a greater understanding of social determinants of health can improve population health while advancing health equity. At this time, I'd like to ask each of our panelists to give a 5-minute opening statement sharing their thoughts on today's topic. In no particular order.
Good morning, everyone. It's a pleasure to be here, and I'm looking forward to hearing from this distinguished panel and from all of you, and I'm sure we're in for a very informative and exciting 2 days. I'm going to start, with all of the funding that has been poured into treating diseases and doing research over the years, the latest health equity report of 2017 still shows that there are marked inequities that are very persistent between the population groups. So why is that? Because we have not addressed the social determinants of health. The World Health Organization, as you just heard, has provided us with some guidelines as to what needs to be done. We need to improve the conditions of everyone's daily life. We need to end that inequity of resources, power, and funding. And we need a workforce that's really prepared to address the social determinants of health. Those determinants run the gamut. They are, and I can hardly read, economic stability, the neighborhood environment, education, healthcare, and so forth. And when I talk about the social determinants of health, I'm really including economic, environmental, and political, because the political also has a lot in determining whether we are healthy or not. Looking at some of those determinants, although we continue to hear that African Americans have the lowest unemployment ever, our unemployment rates are still higher than every other population group in this country. Our income is the lowest, and African Americans, Hispanics, and Native Americans live in high density, are more likely to live in high density poverty areas. This is one map of food deserts in our country. It's improved slightly over the years, but look at where most of those food deserts are. It's where the stroke belt is, where there's more heart disease, where more diabetes in the South, and where healthy foods are needed the most is where they're not, DC included. Ward 7 and Ward 8, 90% African American population, that's where the food deserts are in the nation's capital. We're likely to die, 3 times more likely to die from environmental pollution because we live in the areas where pollution is the greatest. Our schools are becoming more segregated, and this is 2018. This is a 2018 article. And where those schools are segregated, they are less resourced. There are 7 or more states where the states are being sued, and this is probably going to grow because the segregation is growing and the under-resourcing of schools where there are mostly African Americans and Hispanics continues to grow. 7 states are being sued to bring more equity to their educational system. And again, we're not only the most incarcerated population group in this country, and that affects not only the families, but it affects the communities. And as we look to the census that's coming up in 2020, those people are going to be counted where they're incarcerated, taking funds away from the communities that they came from. We have a lot of work to do to address the workforce need that the World Health Organization has as its 3rd guideline. You can see that we continue to be underrepresented in all of as physicians, nurses, pharmacists, and also in the C-suites of healthcare. Physicians, this is a slide of physicians and surgeons, and you can see that even though the 3rd bar is the African American, even though we're about 13% of the population, we're about 6% of physicians. Our medical school graduates are still very, very low, 6% for African Americans, 5% for Latinos, and we have the lowest acceptance rates for medical schools. At the very root of all of this, of course, is racism, which we must begin to confront more directly. The chronic stress that it creates in our community, in the individuals in our communities, is affecting our health, and there's a lot of research being done on this particular area, and I find it really, really interesting. But that stress is impacting our health, impacting our communities, and really needs to be addressed. We're in an early election cycle where everyone is talking about reparations. I think that in the 2 days that we're here together and as we go through this election year, we should be creating the framework for what those reparations ought to be, and they have to be addressing the social, economic, environmental, and political determinants of our health. Thank you.
I'm going to be very Brooklyn and just call a thing when it comes to social determinants of health. First of all, social determinants of health are not new, right? We've all known about it for decades, right? We've all been working, we call it different names, right? We call it disparities, we call it a whole bunch of different names. This is just the new flavor of social determinants of health. And the good news is that it has gotten some national attention, right? And so it seems like folks are starting to move in the same direction around recognizing that it's not enough to pay for a health service, right? It's just not enough, right? To have a card does not buy you health in the United States, right? What your card buys you is health care, right? But health care does not always equal health. And it is critical that in communities all across this country, we teach and we differentiate the difference between health care access to a procedure or a service, and health, which means wellness, right? The ability to live your life, to have a quality of life, right? And as the World Health Organization told us a long time ago, health is not the absence of disease, right? So you can not have a chronic disease and still not be healthy, right? But what we pay for in our system is this idea that either you are diseased or you're not, right? If you're in the middle, you may not have a place to go. So as we start to talk about social determinants of health, I hope we will address the larger issues of equity and justice, right? And I think, Donna, you just did such a beautiful job highlighting every one of the areas of equity and justice that impact health and then therefore impact health care, right? And let's look at it like real plain, okay? I'm a street doc, that's what I do. I'm a pediatrician. I have 2 wellness centers here in Washington, D.C. in Anacostia, D.C., Ward 8, which is the most economically impoverished part of this city, Ward 7, 8, actually 5, 6, 7, and 8. And I see kids all the time and their families who are impacted by what I was impacted by, poverty. Right? I was impacted in Brooklyn, New York by poverty. Came here to Washington, D.C. hoping to find that they were not impacted by poverty. Took the Greyhound up New York Avenue at 17 years old to go to Howard University. And what did I see? Same poverty I left. Right? And we see it again and again. Right? Now, how do we start to solutionize around this? I think our entire industry is starting to recognize that there needs to be a righting of the ship. Right? A lot of the stuff that we paid for and we paid very high cost for were procedures that did not result in positive outcomes, right? Long-term outcomes. Now, the procedure itself may have went well, right? But did it change the health, not the health care, but the health of the person? And did the person get to determine their outcome after that? We're righting the ship. We're looking at what are the cost drivers in health right now, and what will those cost drivers be 40 years from now, 20 years from now. We know that the issue of equity in providers is a big issue, right? Barbara, I was so happy to have you here because the American Medical Association and all the associations are working and have worked on this issue for a long time, but the reality is, the American Medical Association apologized for its stand against black physicians, right, in 2009. And yet we have not seen a significant increase in the number of black or Hispanic physicians admitted to medical schools, right? Out of the black female physicians in the United States, we are 2%. Right? I always say we all know each other, don't we? Right? If you've been in medicine long enough and you're a black physician, you know each other, right? Because there's only 18,000 of us. We could have our own listserv. Okay? And when I started medical school, I'm 25 years in practice now. When I started medical school, there was 1.6. We're now just under 2%. That's not progress, y'all. And we know it. And as a country and as a group of providers, we have to start saying it, right? Call a thing a thing. Look at the social determinants of health and recognize that it is transportation, it is housing, it is food, it is these concrete solutions, but it is also system innovation. It is also process innovation. It is also looking at the very health infrastructure of the United States of America and saying, is everyone allowed to be healthy? Are you actually allowed in the United States to have health, especially in the public insurance format? Right? Folks, does poverty mean that you have to be unhealthy? Right now in the US, the easy answer to that question is yes. The stats tell us that. Right? If you were in the lower 1% versus the upper 1%, the difference in lifespan is 15 years. That's all. No matter what you do in your life, it's 15 years, right? And so that tells you something. It tells you the answer to the story on the social determinants of health. So as we start this dialogue today, I hope that we will address the social determinants of health by calling it what it is. It's injustice, it's inequity, and it is the impact of social, institutional racism and classism in the United States. Thank you.
So my name is Deborah Arrindell. I work at Amgen. So Amgen's a biotech company located in California. So you might wonder why I'm sort of on the panel. But I think part of the issue when we talk about health equity and we talk about populations being healthy, I think part of the equation that has to be part of the equation is access to medicines, because we all know that medicines save lives. But most importantly, I think we're in the era of medicines which can increase lives, help patients become more healthy. So for example, with innovative medicines, cancer, we've basically increased the overall survival for a number of patients that have different types of cancers. However, the problem is that a lot of patients, especially minority patients, are not part of that process. So they're not part of the clinical trial process. So I think when we talk about health equity, we are also going to have to talk about ensuring that there's diversity and inclusion in clinical trials. I think people know a lot of the numbers. For example, although African Americans make up 12% of the population in the US, they only make up about 5% of subjects in clinical trials. And for other patients, such as Latinos, it's even worse. They make up 5% of the population, but they make up less than 1% of subjects in clinical trials. So I think when we talk about inclusion and diversity in clinical trials, I think we need to really think of a strategy that crosses a number of stakeholders. So it's not only the pharmaceutical agents, the pharmaceutical companies that need to be part of this process, but it's other stakeholders as well. As for example, it's the FDA, it's partnering with the FDA, it's partnering with patient groups. So there's a number of stakeholders that have to be part of this process. And again, I just want to go back to this whole concept of medicines and basically where we're moving. So as a lot of people know, where we're moving in this country in terms of drug development, it's more about personalized medicine. And again, if we're not part of that process, then for a lot of us who suffer from diseases such as cancer, such as heart disease, we're not going to be part of the solution in terms of the clinical trials. We need to be part of these clinical trials in order to actually have the data and to have the data that's going to allow us to use these medicines. And it's just unfortunate, but we're just not part of these clinical trials. So I think that from my perspective, and that's really the message that I really want to give here, is that I think as a community, as different organizations, we really have to work together to try to find some solution. And just some parting thoughts. Again, I don't think one pharmaceutical company can do it alone. We're going to need a lot of the pharmaceutical companies to come together to come with a strategy. I think we're going to have to work with patient advocacy groups. Obviously, we're going to have to work with regulatory agencies. We're going to have to work to actually increase the number of investigators who look like us patients. And then I think most importantly, I think it's about increasing the awareness of the benefits of clinical trials.
Hi, good morning. I'm Susan Rogers, and I want to thank you for being asked to be part of this panel on such an important topic here today. I am a general internist and from Chicago, and I've spent almost my entire career at Cook County Hospital in Chicago. This is a safety net hospital where we see anyone regardless of their ability to pay. But I speak to you today as a national board member of an organization, Physicians for a National Health Program, whose single mission is to advocate for universal health care coverage in a country with a Medicare for All program, because we believe that health care is a right. We have over 20,000 members in our organization. Now, currently, we have a healthcare system, if you want to call it a system, that is inefficient, fragmented, costly, and the way it is now, it is unsustainable. We spend almost twice as much as other industrialized countries spend, and yet our life expectancy is only about 43rd. Our infant mortality rate is ranked 30 out of 40 industrialized countries. And our maternal mortality rate is even increasing even more. The number of people living in high poverty neighborhoods has doubled in the last 20 years, and this is disproportionately people of color. Since almost half of Black America lives in states that did not expand Medicaid, that left at least a quarter of the Black population uninsured. In this country, we have an abundance of technology and remarkable medical innovation. Still, minorities continue to suffer and die because they cannot access basic medical care. Unequal health care is a consequence of social inequities, but our current state of health care financing reinforces and institutionalizes this inequity. We should not tolerate these inequities as if they were just a natural byproduct of capitalism. Many jobs pay wages so low that people remain at or below the poverty level despite being unemployed, and then thus they rely on Medicaid. Now, Medicaid does help, there's no question, but historically it has always been woefully underfunded. Access is limited because of this, and specialist care in some areas is even non-existent. For workers who do have an employer-based plan, however, that coverage is now becoming more and more limited with narrow provider networks. There are increasing out-of-pocket expenses with high deductibles, copays, and medication costs that are prohibitive. Underinsurance is now more and more uncommon. Having a medical card or insurance card still does not mean that you can pay the out-of-pocket expenses. So people are making daily choices every day to delay or go without care entirely. Medical bankruptcies are increasing despite having insurance at the onset of illness. And the tipping point is often something that is not necessarily life-threatening. A broken bone requiring surgery or a hospital admission for pneumonia. These problems are easily treated and curable, yet they lead to thousands of dollars in medical bills. We have a healthcare system based on private insurance companies that is driven by profit. It provides care where profit can be made rather than where care is needed. Market forces are not the solution. They are actually the problem. An example in Chicago, breast cancer rates in Chicago were similar for Black and white women up until screening mammograms became the standard of care in 1989. It was then that the gap started widening. White women had decreased mortality from breast cancer than Black women. Initially, this was attributed to Black women, for whatever reason, had more aggressive cancers. However, this was actually proven that this wasn't the reason. The reason why was because the radiologists screening the mammograms in minority communities were general radiologists, whereas those in more affluent, non-minority neighborhoods were specialists, radiologists who specialized in reading mammograms. So what happened? Early cancers were often missed in Black women, and by the time they were diagnosed, they presented with a more advanced stage. Black women also have less care to treatment centers than women in better communities. So a task force was set up, and over the next few years, the gap changed, and clearly it improved. However, to this day, 30 years later from the advent of mammograms, there is not a single American College of Surgeons certified breast cancer treatment in the city of Chicago in a minority neighborhood. There's not one. This is a direct result of a market-driven healthcare system that provides care and services where profits can be made and not where the services are needed. Having access to care will not eliminate healthcare disparities. If you look at a lot of charts out there, they say that access to care accounts for maybe 10% of the effect of the social determinants of health. However, it is an essential part of the solution, having access to care. There's now a Medicare for All bill that has been proposed and sponsored by many, many Congresspeople. This will no longer be there will no longer be an underfunded system for poor people and another system for wealthy people. No one will have to decide whether or not they can afford the care they need based on their finances. Medicare for All will help eliminate the medical deserts that currently exist in poverty-stricken neighborhoods. If you look at the Cleveland Clinic in Ohio, the Cleveland Clinic is the epitome of wonderful health care. It's very innovative, state-of-the-art, yet a mile away, it is one of the worst poverty-stricken neighborhoods in the city with a mortality rate almost 15 years less than right there at the Cleveland Clinic. And while covering more people, we will actually save money by decreasing the administrative waste that currently exists with private insurance, negotiations with pharma and medical device companies to reduce those prices, and allow patients and doctors to decide what needs to be done, not an insurance company. Improving access is an important tool to address healthcare disparities, and I would encourage everybody to advocate for this bill and encourage your representative to sponsor the bill if they have not done so.
So the good news is that over the last decade or so, we've seen a marked shift in how hospitals and healthcare systems think about and recognize health and well-being. Absolutely, we have a long way to go, and we're really challenged with this idea of social determinants of health and how do we address social determinants in an affordable way. But what I've noticed over the last 10, 12 years that I've been in this field is that, one, we've shifted from talking just about disparities, and we're recognizing that disparities are really just differences that are created by inequities, and that inequities are far and wide and deep. And we've challenged each other across sectors, not just the healthcare sector, but really working with transportation departments, working with hospitals and health departments, working with school systems, working with private industry. We've challenged ourselves to think about health and wellness beyond healthcare. We've challenged ourselves to think about health and wellness beyond health systems and what we can do as health systems and health insurance. So I'm encouraged. I'm encouraged that we're understanding social determinants of health in a way that we never did before. I work with an organization, Kaiser Permanente. Kaiser Permanente is the nation's leading integrated healthcare system. We're based in California, and we stretch across 8 regions, including here in this region. And I'm responsible for community health, basically public health, here in the Mid-Atlantic states. And what we believe is that, obviously, healthcare is critical, and we do our best to provide the highest quality of health care possible in our medical centers and our hospitals. But we also recognize that that's not enough, that if we aren't also addressing the social needs, the social, economic, and environmental needs of our members and our communities at large, then there's no way that we're going to achieve the health outcomes that we aspire to. So again, I'm extremely encouraged. I'm encouraged by, within our own health system, I'm encouraged that we get recognized for the quality of care that we provide. I'm encouraged that we are highly rated by objective sources on our screenings for cancer, on our service, on our quality of care. But I'm also encouraged that we've told ourselves that this is insufficient, that clinical excellence is insufficient. As such, at Kaiser Permanente, we've begun to invest in areas that are quite unexpected for a health system, and we're seeing others do some of this as well, investing in housing, investing in building the capacity of nonprofit organizations who serve the social needs of communities, investing in systems and networks that connect our members and our patients to social services, investing in small business development and incubation, investing in jobs, investing in workforce readiness and job placement. These are areas that, again, at one time you would never hear a health system talking about. We believe that if we are to increase health outcomes or improve health outcomes and decrease costs, we have to work in this way. We have to think differently about health. We have to acknowledge that health is wealth, that if we're not also addressing people's ability to access food in their neighborhoods, to access jobs in their communities, to access not just jobs, but livable wage, family-sustaining jobs in their neighborhoods and in their communities. If we're not helping businesses to grow and flourish and be economic engines in their communities, then we're not really realizing our full responsibility as a health system. So I'm delighted to be here. I will be talking a bit about how health systems are thinking even beyond that. What I didn't say is that we, as health systems, nonprofit health systems, you may or may not know, through the ACA, have to invest about 3%, at least 3% of their revenues, annual revenues, in community benefit. And hospitals are going even beyond that. And I'm going to talk a little bit about how we're doing that and how we're thinking about that. But I see progress. I see opportunity. I see hope. I work with a number of communities in the Mid-Atlantic states area here, and we work with nonprofits of various types, and I see the possibilities. And so I'm really encouraged to be on this panel with my colleagues here, and I hope that we can talk and I know that we will talk as much about the problems and the data as we will about the solutions. So thank you for having all of us here today.
So I am glad she led and finished with that level of optimism. Because as I sit here, I am the least prepared person to talk about healthcare. Because at my law school, I had not a single healthcare class, and I'm sitting here with medical doctors and advocates. But with that said, I also understand that healthcare is not about the delivery of a healthcare system, it's about the totality of our human existence in this country. And with that, we oftentimes, and I see this in many disciplines, we talk about the specific discipline, and we have perfect solutions, but we leave out the basic reality of this democracy. It's about policy, which can be pure and great, but when you add in politics and power, the policy goes out the door because profit takes over the conversation. And in the healthcare system is more of that than anything else. And so the solutions that we are seeking oftentimes will not be contained in the policy conversation when the power walks into the door. So in the civil rights community, you know, for me, I love the study of civil rights. And oftentimes we project leadership on individuals who are good speakers but not great leaders, and then we ignore great leaders who simply did not have the charisma of the good speaker, and we miss the strategy behind the outcomes and the successes that we've had. In 1964, we had this thing called Freedom Summer. I live in Mississippi, grew up in Detroit. And I helped the veterans of the civil rights movement organize the 50th anniversary of Freedom Summer. And to my delight and surprise, I recognized Freedom Summer was focused on 4 primary issues to increase quality of life for African Americans in Mississippi. They looked at access to education. Brown versus Board of Education was approaching 10 years old. All deliberate speed, they understood it was like taking X-Lax with a sleeping pill. What you get is a mess when you think about that. They looked at the franchise, that in the democracy, our vote is our currency, and if we were prevented from exercising our franchise, we had no currency, therefore we were subjected to a subhuman existence. They looked at labor rights, that individuals who were working on plantations as sharecroppers lacked the ability to negotiate for their labor, lacked the ability to collectively negotiate, and as a result of that, we were not paid equitable wages, but they also looked at access to health care. And that's the part of the civil rights movement we don't talk about. And it was Dr. Robert Smith who was one of the individuals who created an organization called the Civil Rights Committee, the Civil Rights Committee for Health. I think I got the name right. And he began to see the lack of access to health care. And when the movement began to take momentum, he had a relationship with Tufts Medical School. And he brought a concept to Tufts and began to talk about how can we create a community health care center. And today we're still looking at the rural community health care centers all across the country because his lived experience, along with Dr. Britton and Dr. Aaron Shirley, and then later Dr. Jack Geithner, they came up with a policy that overcame the power at the table to provide access to Black folks in Mississippi and now across the country. The solution that we're seeking in this space will not come from the theory, it will come from the learned experience. And I also learned in that process, and Dr. Smith, ironically, is still practicing medicine like at 84 years old. I wouldn't go see Dr. Smith as my doctor, but I love sitting down talking to him. My mother loves going to see him as her doctor. And he and his colleagues, when I go talk with them, they talk about we must always understand our problem is someone else's solution. Our problem is someone else's solution, and their solution is to maximize profit. So delivery of healthcare in many cases is not about making people well in the sense of preventing the causes. It is about treating symptoms of the causes so you can maximize profit. So there's a reason why whether I'm in Detroit or Mississippi, I drive past fast food restaurants, liquor stores, convenience stores with sugar drinks, and then a retinal clinic so people can go get dialysis. And those retinal clinics are making billions of dollars. There's a reason why I grew up with asthma in the backyard of Detroit, or a child in Flint now is going to be faced with all of the symptoms of the poison water. There's a reason why individuals in Indianola, Mississippi, or whatever rural town in Georgia or Alabama live next to some type of agricultural field where they're still doing aerial spraying on the kids. And as a result of that, those children, me growing up, we have to live with the symptoms of that environmental reality. For the NAACP, we understand health is not about who get access to medicine or not. It is about the whole environment. Is it raining over there? And so for me particularly, I'm probably the least prepared in terms of the healthcare conversation. But I really want to begin to talk about the power conversation, because our solution, I don't think, will be found based on the theories in academic settings. It will be found outside of academic with our learned experience in our training. Dr. Aaron Shirley, before he died about 2 years ago, he began to look at another model, because he was one of the people who talked about our problem is someone else's solution. And he recognized that the solution for us was not going to come within this system. So he began to explore, what are other countries doing? How they're providing access to health care with fewer doctors, without the technology that we have. And he landed, ironically, in Iran. And Iran has a thing called health houses, where they're able to provide more access to early treatment to people with fewer doctors. And he took a group of students over there, and he began to study that system to bring back to set up a health house. And in that, you could actually see more people with nurses and practitioners and other individuals who are trained bare minimum before you get referred to an actual doctor. And he recognized, looking at the data, if you provided that early access to communities, you have fewer people with chronic illness. Now, maybe that's not new to most people here, but to me, I was like, wow, why haven't we done this? He said, because this solution for us created a problem for somebody else. Our problem is someone else's solution, but our solution is someone else's problem. Clinical trials, the more I study them, I get even more concerned because of the genome research taking place, and realizing that there are designer drugs that would treat some people and other people won't have that impact. And we're outside of clinical trials. Are we going to be left out but if we're in the clinical trials, are we going to be left out? Tuskegee experiment wasn't that long ago. So it goes both ways. And whoever have access to certain designer drugs is important if those who are in power care about the community who's getting access, because they either can design the drugs to help us or hurt us, and we need to be in the room so that we can drive that conversation differently. And so I would end by saying, when I'm on panels talking about education or environmental justice, I hope that we have a grasp on the reality of this is not about the subject matter. This is about power. And in a democracy, when it's weak, capital controls. But in a democracy, when it's strong, we can hold capital in check. For African Americans, we got to understand, they may have millions of dollars, but we have millions of votes. And if we don't leverage our currency or our vote to hold capital in check, our communities are subjected to a level of profiteering that will cause us to be ill, both physically, financially, and environmentally. Thank you.
So thank you each for your 5-minute opening statements. Thank you so much. A very quick announcement. There is a pipe that has burst behind the stage. So if you're hearing that water, that's what that is. And they're working on it now. So I know everybody, we can hear it pretty strong up here. Yeah, so they're working on that now. We will go ahead and jump into as much of the conversation as we can. And I'd like to start out with a question that any one of our panelists may address. The American Medical Association and United Health are throwing their support behind the development of billing codes for social determinants of health. The idea is that the codes can assist in documenting patients' social and medical history. So with this newer development, what do you think it says in regards to now the focus on social determinants of health, and what are your thoughts on the development of these codes?
Mm-hmm. Well, I think that's a great idea because as the third principle of the World Health Organization is we're talking about having a workforce that considers at least and understands the social determinants of health. We're here saying that unless we address them, we're not ever going to eliminate health disparities and create health equity. And so I think it's really important. We talk about comprehensive health care. Well, now that even has to go a bit further and bring in those social, economic, and environmental determinants.
Yeah, and quickly, let's talk about those codes. There's two types of codes we use in the payment of healthcare. One is the ICD-10 code, which tells us what you have or don't have, right? And then the other is the CPT code that tells us what we're willing to pay for it, right, for that disease. There are codes in the ICD-10 codes called the Z codes that focus around social determinants of health. Codes like homelessness, child abuse, parental challenge, those types of things, food insecurity. And those need to be expanded, and frankly, they need to be used by providers. Now, let's say why they're not used by providers. Because there's no CPT code, there's no payment necessarily associated with that code. And those Z codes can't be used as the first code, right? So if you have nothing else wrong, but you are homeless, that should be something that we're interested enough in that we pay for the knowledge of helping you with that homelessness, right? And that the other piece of this is when it comes to wellness, right? Our goal, all of our goal, is to keep everybody well. I'm a pediatrician. When the OBs throw the baby, we catch the baby, all right? And our job is to hold on to that baby, okay, for 23 years, some 18, but we go 23 years, and then we hand it off to the internal medicine docs as a beautiful adult. That's what we're hoping for, right? But right now, honestly, if you look at our payment code system, wellness, there are very few opportunities to bill for keeping somebody well, right? So the truth is we're a disease-focused system. right? And as soon as you get a diagnosis or a disease, the healthcare system churns. That's the engine, that's the grease of the healthcare system, is disease, disorder, trauma, right? When you stay healthy, right, the healthcare system, if you just look at healthcare, comes to a halt when it comes to payment. And I think what a lot of us in this industry are working on is reforming that, right? That's what I call process innovation, right? Where we're looking at how do you start actually paying properly for primary prevention, secondary prevention, and frankly, keeping somebody healthy and allowing them to reach their quality of life, happiness, sanctity, security.
You know, part of the problem, though, I see with using these codes is that if the person never comes in the doctor's office, the code is never going to be done. And as long as the people who can mostly benefit from the services that these codes say they will provide will never be in the doctor's office. Those services should be out there anyway. And so I can see this making things more complicated, burdening providers without really being, I'm not sure how you can really follow the trail to make sure without it being so cumbersome to make sure that people are getting the benefits from these codes that you say they will.
Yeah. I think the other challenge, of course, is that whether or not we have these codes, if we are screening for social determinants of health, we also have to have that next step of engagement so that we know what to do. We have physicians within Kaiser Permanente who I hear from all the time who say, you know, we want to be able to screen for conditions that occur beyond what we're doing here in our medical centers, but what do we do? What is the system that's then set in place for us to be able to efficiently refer, for us to be able to track, and for us to be able to know whether whether the patients are complying, whether the patients are able to get to the social services. So I think there are different steps that have to be taken to enable providers to be able to use the codes, to be able to refer properly, and to track patient outcomes. Kaiser Permanente is both health care and coverage. So, and I say that not simply as a commercial here, but really to say that we believe that our approach to healthcare is healthcare for the future, because we are absolutely concerned about healthcare costs, because we're paying those costs. So we're paying for the healthcare and we're paying for that coverage. So when those things are integrated, there's a higher, I guess, level of accountability as well as responsibility to control costs. And when we're keeping all of the care that's provided within our system, we're also able to control quality. So controlling quality and costs, we believe, is part of that healthcare model of the future.
I have no concept what a Z code is, but I think it's important.
Okay, well, let's go now to maybe some more individual questions. Dr. Rogers, access to care is just one of the ways to address social determinants of health. What impact can the Medicaid for All bill play in addressing social determinants of health? And can the Medicaid buy-in option that some states are considering have the same kind of impact?
Well, one of the issues with these buy-ins, both Medicare and Medicaid buy-ins, is that they still are based on an insurance, private insurance company base versus the Medicare for All, which is not. And even in these buy-ins, what happens is it still doesn't eliminate out-of-pocket expenses, which is really prohibitive for people being able to get the care that they need. It doesn't eliminate deductibles. It still has restricted networks. It still has pre-approval. You have to get things approved before you can get certain care. So that it really doesn't solve a lot of the problems to access that people already have right now with any of the privatized plans, whether it's a buy-in, whether it's Medicare Advantage, whether it's Medicaid managed care. it's still restrictive because of the additional out-of-pocket expenses, restricted networks, and pre-approvals that need to be done. So I don't see these buy-ins, these options, as really solving a lot of the problem. I think that they're just adding, it's still building on a base, I think, that is flawed and not really solving the issue.
Dr. Christensen, and for the other panelists, feel free. I know I'm kind of mentioning these questions by name, but if you have thoughts around the questions as well, please feel free to chime in. Dr. Christensen, the Health Equity and Accountability Act, how does that build on the advancements of the Affordable Care Act, and what other health policy should individuals interested in addressing social determinants of health be mindful of?
Well, thanks for the question. The Health Equity and Accountability Act was first introduced in 2003. We finally got to a hearing maybe 8 years later. Never got it passed, even though we've introduced it in every Congress. However, when we were developing the ACA, we took a lot of those provisions that were in the Health Equity Bill and got them included in the Affordable Care Act. We didn't get all, and so there's still some work that we think needs to be done. We always knew that the Affordable Care Act would need to be improved upon. There's a movement to do that now. And so I think this is another opportunity to take some of the provisions of the Health Equity Bill that we were not able to get included and now include them. Also, if there's a way to ensure that some of the provisions that we did get included get more funding, I think that's important. We created community health worker grants, but they were never fully funded. I think we need to increase some of the provisions around creating that health workforce that we need. Throughout the years, there's always been a fight to make sure programs like the Health Careers Opportunity Program are funded. That needs to be more funded, and it probably needs to morph into a program that gets even into the earlier elementary school grades, as we see that the schools are not really providing our children with the kind of education that will enable them to even think about going to medical school. One of the things that we did not get in the Affordable Care Act was our health empowerment zones. It's still a part of the Health Equity Bill. I think that became the community assessment provision that the community hospitals are required to provide every couple of years. But the health empowerment zones were created to begin to address the social and economic determinants of health by ensuring that once a community came together and determined what their priority health challenges were, that they would be able to get that designation, and it would give them priority access to the different grants, and not just healthcare grants. It could be from small business, EPA, agriculture, whatever they identified as needing to be addressed in their community to improve those determinants of health. They would be able to have priority access to grants that would enable them to do it. And so I think that's a real important part that we did not get in. Maryland, anyone from Maryland here? Maryland, Shirley Nathan Pulliam and Anthony Brown, when he was lieutenant governor, always took our ideas and implemented them in Maryland. And so Maryland has 5 health empowerment zones, and they're doing very well.
Dr. Arrindell, you mentioned briefly about the importance of clinical trials. About 80% of clinical trial participants are white. What is the link between health equity and diversity in clinical trials, and why is this important to social determinants of health?
I mean, again, kind of what I said in the beginning, I think when you talk about health equity, you also have to talk about access to medicines. And there's a lot of innovative medicines now. My particular field is oncology, so that's where I spend most of my time is oncology. But there are innovative oncology drugs that are increasing people's ability to live. You know, the same thing with regards to other therapeutic areas such as heart disease. And so if we're not part of these clinical trials from the beginning, then we're not going to be able to have the data then once the drug is marketed to really be sure that these drugs are going to work in these particular patient populations. And I think it's just real important that people have to understand, it's the, you know, of course, I'm saying this, but you know, medicines do save lives. And for some people, some of these drugs can be life-saving, but if you're not part of those clinical trials, then you're not getting access to those drugs. And then at the end of the day, we're not going to end up with that real-world data, because that's really what we need. We need that real-world data. We really need that evidence that these drugs are going to work in the patient populations. So to me, that's the link between health equity and why we need to be included in these clinical trials.
Thank you. Mr. Johnson, hello. You popped your head up. For almost 10 years, the NAACP and Robert Wood Johnson have worked together to address issues in the Black community, such as childhood obesity and access to health care. Most recently, you've taken that partnership to focus on health equity. Can you share some of the details of that partnership and how it specifically addresses social determinants of health?
So I've been in this position a year in October, and I began to evaluate our relationships with not only foundations, but other partners. And with Robert Wood Johnson, you know, I think it's important for us to address issues of obesity and all the other things, but for the NAACP, it's important for us to look broader. And so as I began to negotiate with Robert Wood Johnson, and they also began to look at their strategic approaches, we landed on the space to talk about the whole health of an individual. What are the school environments for children? What's the community environment for families? How our elders are able to participate in their community with exercising outside without being in fear of their community environment? What's the totality of health? And so our partnership moving forward will be looking at the broader scope. You know, my mother is 75. She thinks she's 50. And right around October of every year, she ended up in Mississippi with me because she liked to walk. You can't walk in Detroit because it's so cold and the ice, and she's scared she's going to fall. But many of her friends, they don't have children. They can go away and then come back for the winter. But unfortunately, there's no community center either. There's not access for them to continue to exercise because there's a group of them. They go walk 4 or 5 blocks, and they got some good gossip. They'll walk for a mile and back. That's important because that level of exercise allows for a quality of life that our elders should enjoy. And so with our relationship with Robert Wood Johnson, we're looking broader than that because it is very clear that the medical community, as I said earlier, is some good nonprofits. It's a profit game, not a people game. And so how do we create conditions where people are healthier just by their physical activity and what they eat and the environment they're in? And when children sit in schools, there's not lead paint in the schools. And unfortunately, with all the years of knowing that the paint that's on the wall of a school can create deficiencies in children, we still have not addressed it. We have not addressed mold in some schools. And so for us as NHC, as advocates, public policy is moved by noise. And so we need to add our noise to try to shape public policy differently than how it's been shaped in the past.
Ms. James, what role can hospitals and healthcare companies play in addressing healthcare? And then you kind of mentioned this a little bit in your opening, but what are some of the things that are already being done that individuals may not be aware of?
Yes. Hospitals spend about $780 billion in total annual expenditures, about $340 billion in purchases, so supplies and other kinds of things they procure, and about $500 billion sit in our investment portfolios. That's money that can be invested in communities. And increasingly we're seeing hospitals who are recognizing that they have the power, the influence, and the responsibility to invest in communities in a much bigger way. I mentioned that the Affordable Care Act requires that nonprofit hospitals invest 3% of their annual revenues through community benefit, which is typically through grants and healthcare, so charitable healthcare, providing free or low-cost healthcare to individuals. And these dollars really need to be directed at individuals throughout the community, not just those who, for example, who are our members. So at Kaiser Permanente, we serve 12 million members across the country. Our community benefit dollars, about $2.3 billion last year, were invested in communities irrespective of whether you're a member of Kaiser Permanente. But in about 3 years ago or so, the Democracy Collaborative, Ted Howard from the Democracy Collaborative and Tyler Norris, then with Kaiser Permanente, wrote a publication called Can Hospitals Heal America's Communities? And the idea is that hospitals that take on an anchor mission, because they are anchor institutions anchored in their communities. Typically when a hospital is there, it's there for multiple decades. And the idea is, can we hire differently? Can we procure differently? And can we build differently? Can we do that with an eye on the local economy? Can we hire locally? Invest in companies in our local areas when we're procuring our supplies and our products? And can we build with an eye toward economic revitalization and economic development? So hospitals are really thinking bigger about that investment in communities and the investment beyond community benefit dollars. And this approach is really to provide more resources and more tools to support communities, both as a way to improve health outcomes, but also as a way to decrease the cost of healthcare. So that's a really interesting and also positive way that hospitals and hospital systems are investing in communities and innovation. So I leave you with that. I know we don't have a lot of time.
Thank you. We'll do one more panel question and then open it up for the audience to ask questions themselves. Dr. Wilder, Sistine is a corporation as a leader in government. Centene. Brandon only told me that like 5 times before the panel started, but that's okay. That's okay. I knew I wasn't going to get it right. But they're a leader in government-sponsored insurance. What opportunities exist for the corporation and other health plans to impact health outcomes and specifically address social determinants of health?
Yeah, thank you for asking that. I think, you know, for Centene and the other insurers in the federal space, in the Medicaid, Medicare space, honestly, we recognize that we're at a time in our nation where there has never been more opportunity, right, to innovate and really create change across the systems that impact health, right? And again, not just healthcare, right? So even housing, food, transportation, right, community violence, right? We're all interested in what makes a population healthy, right? And how do you drive those outcomes and how do you pay for what matters, right? Even if that thing that matters doesn't come with an MD degree or an RN degree, it may come because you are the community health worker who can get people into the spot that they need to be in, right? And then that should be the thing that is paid for. So there's great opportunity to innovate in this space. Centene, we talk about transforming the health of our communities one person at a time because we really believe that every individual matters, right? And their health outcome matters. All of our health plans across all 30 markets are locally governed, right? So they control their own resources and they get to invest in their own communities. And we look at some issues in a longitudinal way, like our investment in St. Louis around the call center that our leadership built after the Michael Brown shooting, right, to employ hundreds of people who were having challenges getting employment in that community, right? And over again, we see this idea of how do you invest in a community and help that community then reinvest in itself, right? Make those dollars work. I love what you were saying about vendor supply. The leadership of Centene has supported looking at every single vendor relationship we have, right? And saying, are those relationships fairly competed for? And are they diverse, and do they solve the problem of getting the solution that we need in the right place at the right time, right? We also look at our contracts, right? And we're now all in a system in the United States where everybody's moving towards value-based contracts in healthcare. And what that means is that we really have to invest in the providers that get the job done, right? And a lot of times that's not a brand, right? It may be small to medium-sized business providers in a community, but they're effective. And so we look at all of those streams.
Thank you to all of our panelists. We're going to go ahead and open the floor. I see the lines have already started for question and answer. If we can start here.
Thank you very much. Okay, great. So thank you for the opportunity. My name is Arrindell. I started a small organization, Physicians for Criminal Justice Reform. I was very heartened to see on Dr. Christensen's slides that she mentioned mass incarceration as one of those social determinants of health. Great panel. I could have questions for all of you, but if I could get some advice, how do we as physicians get outside of the strictly healthcare things that we do to try and affect these social determinants? How do we affect something like mass incarceration? How do we talk to politicians, officials, and let them know that these things actually have a health impact and we as physicians have a role in pushing these things forward?
I'll jump in. I would say start locally. You know, figure out from your perch, what are some of the issues that are concerning to the community that you represent, and how you can be a part of the solution. It's a really good book called The Good Doctor, written by John Dittmer. And it talks about the individuals who was part of the civil rights movement and how they really started locally. And when there was a movement, they built their practice around what was needed. But we also recognize we can do good and do well, because you got to eat too. But start local and then build from there. And movement starts from the ground up, not the top down. And so mass incarceration is a problem. But if it's not a problem in your community where you serve, identify the problem in your community and then build up.
Can I just say a quick code? Right? Code for incarceration. For families who have somebody returning from incarceration, code for it. There is a Z code around parents who are incarcerated. Now, why is that important? It's because data counts if you count it, right? And what the American Medical Association and other associations have been very, very good in saying to doctors and nurses and physicians' assistants is, if you don't circle the code, we don't know it exists in the payment structure. And even some simple things like telephone calls, right? Doctors weren't coding for telephone calls until there was a challenge to code for telephone calls, and all of a sudden, the payment now is associated with telephone calls. So let's encourage our colleagues to circle those codes around all of the social determinants of health, but incarceration is one of the ones that's least coded for.
Thank you.
Make sure that everyone in your community is registered to vote and goes to vote.
Okay, we are somewhat limited on time. I see that we have about 5 more people in line. If we could just stop it at those 5 questions and then be very specific with your questions.
Okay, great. Good morning. My name is Jean Drummond with Healthcare Dynamics. Absolutely awesome, panel. And I especially want to I have something to give free and then also a question, particularly for Dr. Wilder. I just love what you're saying. So clearly transformation is here. You know, we're moving from a system of volume to value. You know, clinicians on the ground, we call ourselves a policy to practice. So understanding MACRA and how it works on the ground with a clinician and as a clinician. Doctors are struggling with MIPS, APMs, you know, what's my number? How do I make it, how do I make it happen? So a part of the work that we've been doing in practices is giving them the tool to collect the social determinants, right? And then certainly also the tools to deal with it. So on Bertha and other tools. And so I want to just share that if anyone is interested, we have a tool. It is free. It is helping. We're reducing emergency room visits. We're helping individuals. And so I'd love to share that with you. It's called the Caring for Your Health tool. But I want to ask you specifically about patient engagement and provider burnout. I mean, clinicians are just dropping on the droves. I mean, they're just tired of this. So talk to us a little bit about, as you see us moving forward in this value-based system, it's all about, the value proposition. Where are the clinicians that are driving the greatest quality with the lowest for the lowest cost, but also to the vulnerable population? Talk to me about your thoughts at Centene that you're doing, and also to Celeste at Ms. James at Kaiser around patient engagement and provider burnout. How are you?
Well, quickly, in terms of provider burnout, I'll tell you, we're very entrepreneurial focused, right? We believe in entrepreneurship. We believe in diversifying what providers can do in their communities. And not everybody needs to be employed to do that, right? So we don't believe the practices are dead or that small clinics and small centers aren't vital. We think they're vital to the solutions that are going to come from the future. And that's where innovation lies, in those people who will take the risk and put some stake in the game, right? In terms of patients, right, one of the things that we were happy to hear is Adam Bowler from CMMI say, patients as consumers, right, within the public space. We do believe that public patients need more information, right, about what's spent on their behalf, right? And frankly, let's stop blaming people for bad health outcomes let's stop that.
Right, they're not non-compliant, right, absolutely, good. And you're exactly right. CMS does have some free resources for clinicians. I'm happy to share that information.
Thank you.
Good morning, and thank you also to the panelists. A great discussion this morning, and I also have to say thank you to Doc, who worked with us a lot on the ground around HIV, Donna Christensen. Thank you for your leadership on that. And actually, my question comes out of that experience, and you just began to touch on it, and it's really for the whole panel. Is there a way that we can message, health and well-being is not the absence of disease, and do it in a way that people don't feel bad when they get a diagnosis that is challenging? We have seen it now in HIV since the beginning. We spend all our time in prevention trying to convince people to change behavior and not get this disease. And then when somebody gets it through natural life experiences, people have the weight and the burden of doing something wrong and bad upon them. In HIV, we call it stigma, but I think in most other disease areas, it's shame. We think we failed. We get a diabetes diagnosis, oh, we ate wrong. Our hypertension is off the chart, too much salty food. I mean, everything, every diagnosis, even, gosh, he was running every day, he was physically fit, and last week he died of a heart attack. Oh my goodness, what went wrong? And those of us who are African American, we live with feeling bad. We start the conversation here about how we understand who we are and our experiences with racism. Can we begin to start to change the narrative on health and well-being so that we can feel that we can be empowered to come forward? Not feel bad if we feel sick. Not feel bad if we get a diagnosis that is overwhelming. But just recognize in the African American community and many minority communities, we're going to get sick. But it doesn't mean we're bad people. And how do we break that dialogue down so that we can come forward and feel okay? We don't want to feel bad and have a cancer diagnosis and never come back to the doctor because we're walking around with such shame. That we didn't do right. We didn't eat all the green vegetables. We didn't take all of the antioxidants. We didn't, So can all of you speak a bit about how we message this thing differently so that we feel okay about promoting health and well-being, but we don't inadvertently shame our patients and each other when we get sick and we don't do well?
I think it's I think it's really important that we do that, and I think you started along that line in your last response. You know, I'm really learning about this allostatic load and weathering. Wouldn't that really it's not something that we did. It's all of this stress of hundreds of years and how it has altered our physiology and in some cases our genetics. And so, you know, I think people understanding that may help, but we need to find a way to change that narrative so that people don't feel that it's all that they're caused their disease. But you know.
And I'll say quickly that disease is not inevitable. We have convinced the American public that disease is inevitable, and it is not. Right? Most people will not get a disease, so let's stop waiting for it. Right? And most chronic illnesses are reversible. Right? And we have to start requesting that, requiring that, right? That part of the conversation needs to be more valued, right? What is valued right now is the prescription. And we have to say the prescription is important. It's important that we have the right medications, right? But it's equally as important that we focus on primary, secondary, and tertiary prevention.
That are standing the mics, I encourage you to approach the panelists afterwards.
Unless they ask them all one time.
Okay, one more question.
1, 2, 3, 4.
Right here, please.
Good morning. I'm LaVarn Burton. I'm President and CEO of the American Kidney Fund. I want to thank all of the panelists and also especially our newest board member, Dr. Christensen. I'll try to make my question very brief. We deal with patients who, you know, by definition, have a pre-existing condition. And in dealing with insurance companies, what we see their activity focused on is how do we move those patients, those expensive, sick patients, off of our rolls? How do we increase, you know, their out-of-pocket cost, et cetera? A couple of you are from the insurance industry, and you talked about the power of the purse. That's where the money is in many instances. They're paying the bill. Some of you, and Centene and Kaiser, have done some things to try to deal with social determinants and try to deal with the communities. How do you, as being part of that industry, spur on others, the Uniteds, the Blues, to do more of that and to change their focus? Because in the end, that's going to help to improve care for patients, and also long-term, it will also help to deal with the expenses that they have. We focused a lot in the last few years on the fact that insurance companies are suffering in the qualified health markets. Whether that is true or not, when you look at their total overall margins, insurance companies are not financially suffering, and we need to bring more attention to that.
From a non-medical vantage point, I'm not practicing law because of the fight around tort reform. I seen my friends make a lot of money. I didn't get in on time, so I didn't make any money. But I did recognize something very clearly as we were talking about tort reform. And the argument insurance companies made to doctors that if we had this, your malpractice insurance will go down. It didn't go down. What we really need is insurance reform. So we can right-size the marketplace, because there's no reason why we're looking at the delivery of health care in other countries, Canada and Europe. It is much more efficient, effective, and in many ways cost allowable for citizens. But in the United States, we have these crazy costs. But we've never had a real conversation about insurance reform. And I think that's really where we need to go.
So
that's
let's give
Medicare for all would do.
I will just say really quickly that I don't want us to be fooled. The economics of healthcare has proven time and time again that the market drives the solution, right? So what you demand, you get in healthcare. When we demand disease management, you get very high cost healthcare, right? And you get more disease. When you demand primary prevention, you will get less disease. Like that. And so it doesn't matter, nonprofit or for-profit, there are great solutions across the United States, There are great, where we see it's economically viable solutions like that, but the demand has to be there. In like every big market, the demand has to be there. So consumers have to become empowered to say, I actually don't want to be sick for 50 of my 70 years. Okay.
So we're going to end on that. Let's give a thank you to our panelists.
Thank you so much.
Thank you for joining us for this important conversation. Enjoy the rest of the symposium.